Hi. Hi, everyone. I'm Dr. Diana Bitner. I'm here with my partner, Dr. Egan. And to introduce tonight's topic, knowing heart disease, I want to talk about, one of the main inspirations for me to start True was knowing how women develop heart disease different than men, including menopause. My first published study showed how our method, waypoints, actually reduces waist circumference in women 45 to 60, which is one of the risk factors for heart disease. So, here I am with my partner, Dr. Egan, board certified in internal medicine and obesity medicine, to show how, 16 years later, we specialists can work together so women don't have to be afraid of heart disease. So, Celia, thank you so much for leading this topic, and I look forward to this conversation tonight.
Yeah. And, when I was in internal medicine training, we dealt a lot with men and women that were going through heart disease and had a lot of cardiac conditions. And I think sometimes women forget just how important their hearts are. And women also forget that 1 out of 3 women will die from heart disease. We hear a lot about cancer and we think a lot about dementia because it sort of affects our day-to-day lives. But the fact is that a lot of women will die from heart disease. And in fact, I have to admit, one of my guilty pleasures is reading celebrity news. And I was reading that Clint Eastwood's partner, who was this lovely woman of the age of 61, just most recently died of a heart attack. Here she was, this beautiful woman living a great life. And, life was just sort of taken away from her, and how tragic.
Yeah, with access to everything, right? Access to care.
Absolutely.
And what is fascinating to me, always has been, is that heart disease is mostly preventable. It's about starting early before menopause, and it's being committed to saying, I don't want heart disease.
Yeah, absolutely. And I think, I always tell my patients this as their primary care doctor. One of the things I do not want to say is, well, out of nowhere, they had a heart attack, right? That's just something that really shouldn't be a statement that a doctor shouldn't say, because we have a lot of tools and techniques now that are available for any person to get a better snapshot of where they're at. One, in terms of cardiovascular risk factors, and 2, what's their actual disease status, which are 2 sort of separate ideas.
Yeah. I'll never forget, this was probably 15, 20 years ago. I was in the hospital on call, delivering babies, and I got called up in the evening to see a woman on the heart floor. So when an obstetrician is on the heart floor, that's not a good thing. And I was asked to see her because she was having vaginal bleeding. Well, I walked in the room and she looked at the wall and she's like, not another doctor. And I said, help me out here. How can I help you? And she said, well, I came in last night, I broke my hip, and on the operating room table, getting my hip fixed, I had a heart attack. And so she was on the heart floor because she had to have a stent placed emergently, and she was on blood thinner, and now she's bleeding vaginally. And long story short, I did an ultrasound. I diagnosed her with uterine cancer. And here she was, a grandma of 12, living in Hudsonville, living her best life, but she took care of everyone else and not herself. So here she is with 3 preventable conditions: osteoporosis, obesity, heart disease, and uterine cancer. So thankfully, her stent, she did well, her hip was fixed, and her uterine cancer was early enough that she was able to be treated. But again, she didn't have to have any of these things. And that was a big aha moment for me. So again, for you and I to be here together, Celia, is just a dream come true, that we get to work together to help women not suffer like she did.
Absolutely. And I think one of our favorite things to do is to get women to understand where they're at and understand where their role of some different lifestyle factors plays in developing these chronic disease factors.
Exactly. And I just had, this was in the room. So this book that I wrote, it's called I Want to Age Like That. Again, this was inspired by women not needing to develop heart disease. And, this is the outline of the study that was done in 2008. And so coming back to that, our process is called Waypoints, or WAI, who am I? And it always starts with, in each area of wellness, what do you want? What is your picture of self? So when we ask patients, what do you want? A patient today said, I want to retire and hang out with my grandkids, travel with my husband, and I don't want a heart attack. So that's her picture of self, right? So if women commit to it, they're more likely to reach it.
Yeah. And I think one of the first steps is to even understand sort of where you're at in the disease process. So when we think about, and I'll tell this a lot to women, for a long time, the only way that we could diagnose coronary artery disease, which is basically disease within the main piping that's supplying blood supply to the heart muscle, that's called coronary artery disease. The only way we could diagnose that was off of basically we call it a cardiac catheterization. And that's where they thread all these little teeny tiny wires up through some of your major arteries, shoot dye at the heart, and they take pictures and they see if there's any sort of blockages. As you can imagine, that's pretty risky, right? We're threading wires and sharp things up into your heart and these important arteries, and there's major risk involved. So we really only reserved that type of diagnostic study for patients who we really thought had coronary artery disease, meaning this is women who were having chest pain, they had EKG changes, maybe they had a stress test that was very clearly positive, meaning as their heart was asking for more blood, their blood supply could not keep up, and we were willing to take that risk to do a cardiac catheterization. So for a long time in the office, because that seemed really risky, what we did was we looked at risk factors. So we looked at women's cholesterol levels. We asked about their family history. We asked if they were smokers. We looked at their blood sugar levels and a variety of different things. And we basically came up with a guess. And based off of those different sort of risk factors, we'd say, you've got a pretty good shot of having coronary artery disease. Let's treat you as such. And maybe we'd put you on a bunch of different medications. Or we'd say, nope, you're really low risk. Therefore, we think the odds are that you don't have it. So go about your daily life without talking about it. And because neither of those options were that great at actually being accurate, because a lot of women still had heart attacks, despite maybe being considered low risk, there's a lot of other tests that have been developed now to sort of look for actually coronary artery disease without having that really high risk procedures that we've, sort of reserved for those extreme cases.
Well, Celia, too, and what inspired me way back when is when I heard Dr. Mers speak at a women's health meeting. And what she talked about is, and Dr. Mers now heads up the Barbara Streisand Heart Center out in California. She was a cardiology fellow at Pittsburgh. And she was like really confused because she saw these women come into the ER and they would have atypical chest pain. They would have nausea, fatigue, and they would have a stress test. And the stress test was positive. And then they would get a heart cath, and the heart cath was negative. So the dye in the heart vessels, it looked like the vessels were clean. And so the cardiologist, using the tests available at the time, would say, you're fine. Go home. It wasn't a heart attack. I don't know why your stress test was positive, but go home. And these women would go home and unfortunately would pass of a heart attack or would die of heart disease. And so she thought that we don't have the right test for women who have atypical chest pain. And what's fascinating to me is a man and a woman can have the same amount of plaque burden, but a woman's going to have a negative cath where a man's going to have a positive cath because she hides. Dr. Mers talks about we hide our socks in the closet and the guys leave their socks in the hallway. So if you talk about, like you were talking about different tests, the cath versus a CAC.
Yeah. And I think one of the things to think about is when you think about a cardiac cath, what that's doing is it's tracing out what we'll call the lumen, or that's the area that the blood flows through. So if you develop plaque in the way that traditionally a man would develop plaque, it's very clear that there's this point that narrows down at one, we call it like a really proximal point where it narrows down at a very focal point. And it's very clear that there's not enough blood flow in that area.
Missy, do you want to show that picture? Perfect.
So this is a great example of what we're talking about. You can see that the blood prior to that yellow part that we would consider to be plaque and afterwards is kind of moving pretty free flowing, right? And the rest of the blood vessel wall is quite open. Women, on the other hand, sort of evenly develop plaque in and around the entire wall. And when you would shoot dye into the lumen or where the blood flows through, you would notice that there wouldn't really change. And there's no way of looking at with a cardiac cath, looking at the outside wall. So you would assume that there is no plaque and that everything for the most part is fine. And the problem with that assumption is we have another picture of sort of how this progresses is it can get a little dangerous. The one other picture, Missy, where we're kind of looking through the stages of progression. One of the problems with not assuming that there's plaque is it can reach what we consider that late stage or a complicated lesion, where that plaque it's an active lesion, meaning there's active inflammation that's going on, and it can rupture. And that blood moving through there does not like that, and it will clot. And that going from, as you can see, even 50% flow to 0% flow obviously is going to cause a lot of problems to that heart tissue downstream. And then women will end up dying they actually don't die from the lack of blood flow. They'll die from what we'll call an arrhythmia, meaning the electricity of the heart gets really upset and it starts basically fluttering, and then the heart doesn't beat the way that it should. And you can't get blood to your heart itself or the brain. And then that's why women sort of pass away.
And what's so sad is how women are more likely to die from their first heart attack than men. So men might have a small heart attack and then more progressive, where women tend to die of that first heart attack, right? Partly because the symptoms are more silent and the disease progresses in a different way.
Yeah. And right, which is quite frustrating. So you can imagine that if you're someone who's looking just at the way that the blood flow is moving through and not really giving women a fair review of whether or not they have coronary artery disease, that we really could be missing sort of a lot of disease and opportunity sort of to treat that and limit the progression of some of that disease process forward.
Right. So I think this is so interesting, but I want to go back to picture of self, right? So if a woman comes in and says, I don't want heart disease, it's first figuring out if that's reasonable, right? Like, is there even a gap? So we have to determine what is her place and process? Where is she compared to her goal? And so as we say, okay, she doesn't want heart disease. She wants to be a 3. She wants to be the healthiest she can be. But then it's figuring out, what is that gap? Where is she? Does she actually have heart disease right now? Or are her vessels clean? Her risk factors are really low, and she is a 3, and we can help her stay that way, versus maybe she's a 2, or maybe she's even a 1 where she's got active heart disease. So would you want to talk about how we can define that gap? You mentioned a lot of risk factors. So how would you go about that? If someone walks in the door, we figure out, what is your gap?
Yeah. So, when we first start to talk to someone, the first place we do start is at risk factors. And we think about some of the bigger ones. So tobacco use and diabetes tend to be the worst, right? In terms of hazard ratios of what sort of progresses coronary artery disease. We also look at some other factors like family history, high cholesterol levels, and we look very deeply into different types of cholesterol aspects that can be important. Chronic inflammatory diseases are also lead to, for women, a increased risk of coronary artery disease, such as having like rheumatoid arthritis, HIV, or another immune process. And believe it or not, actually having a lot of really stressful events actually is a risk factor for developing coronary artery disease. So if we think about some of the more risky positions like diabetes or tobacco smoke, we would sort of start talking about tackling those first, because that's almost an automatic that we almost sort of assume that they would have some sort of coronary artery disease without doing some of the advanced testing that we do. Knowing that Dr. Bitner and I really want to leave no stone unturned, for most of our patients, we'd recommend something called a coronary artery calcium score, and that is looking for coronary artery disease. I don't know if we want to throw that picture sort of back up again, Missy, of sort of the different progressions.
This is good.
So what they're looking for when you're looking at a coronary calcium score is actually some of the plaque formation sort of down the way. So maybe not some of the earliest plaque formation, definitely some of the later plaque formation, but sort of that middle tier where you're starting to see the beginning of some coronary calcium that's being formed. You have to imagine there's an active inflammatory process at the blood vessel wall, which moves in those cholesterol particles into the wall. Your immune system is like, what is this? This is not supposed to be here. It's starting to do its job, which is starting to wall off some of those particles. And that's what creates those plaques. And what it leaves is sort of like a calcium shell. And that's what this CAT scan is measuring and looking at.
And I love how this score can be so helpful for people, because again, if their risk is low, as in even it's 0, there's no calcium. And I got to call a couple people today and tell them their score is 0. There's nothing there, versus people who have progressive risk. And, even that 100 to 300, 399, right? We can help them stay there and not progress. And that's what I love in terms of secondary prevention.
Yeah. And so even, even if you have a wall that has some plaque formation, what we're really trying to do is prevent that last sort of complicated lesion, which is really, I think of it almost like a burn on the inside of the blood vessel wall. And if you were to burn your skin, what do you see? It's like red and oozing and pussy, right? If you can imagine that on the inside, that's what we're trying to prevent. And a lot of the times when we're talking about using different medications, it's not necessarily to get to some target numbers, which I do think is important, but a lot of the times we're talking about just calming down that blood vessel wall so the blood can sort of flow freely and put you at a lower risk for having that lesion rupture and having kind of an acute clot.
Well, I love that analogy of the burn, because we want our skin to heal again, so that maybe a little scar that's underneath, just like we want that skin or that endothelium, that lining of the blood vessel, to heal back over so it's nice and smooth. And I tend to be maybe even a little bit more common sense, in the sense of, like, you think about the lining of the blood vessel. It's going to be more sticky if your sugar's high, right? So if you can get your blood sugar down and keep it in normal range, then it allows that skin of the blood vessel to heal. We know that vitamin D actually has receptors on the endothelium. So if vitamin D levels are better, the skin is healthier. And then comes in the other risk factor that I love as an OB and menopause specialist is when your estrogen is low, that blood vessel lining is going to be stickier. So one of the most dramatic risk factors for heart disease is menopause. So we know, for example, women who have both ovaries removed, they have surgical menopause before 45. This is a study by Dr. Manson. It showed that her risk of heart disease is way more than it would have been if she had kept her ovaries. So her risk of a heart attack might be at 60 versus if she had kept her ovaries, it would have been at 70. And so, again, this is what inspired me so much in this, is that if we can look at the benefit of estrogen and how this plays into it, it's super important.
Yeah. And I think, so first of all, I mean, even just a pause for a moment to think of how kind of just like intense that is, right? Women who don't have estrogen, which is not a common thing that even in my internal medicine world is really discussed, right? When we're on internal medicine rounds, we are not saying, oh, they're in premature menopause. We, in the cardiac intensive care unit, right? We didn't say that, right? But of course we should have, right? Because this is such an important part. And I think again and again, I love our work of just continuing to educate not only patients, but even doctors about how important it is to sort of understand where women are at in terms of their phase of ovarian function.
Right. And let's say a woman can't take estrogen, right? Then, or chooses not to, it's then understanding we have to be a lot more aggressive in terms of, how can we help her prevent? So if she wants to be a 3 and she's a 2 because of risk factors, like, how can we help her? So let's say her CAC is 100 and she can't take estrogen. Dr. Egan, what would you do for her?
So, of course, we want to talk about if she's a tobacco user, 100%, we'd have to end that, right? And working really hard on making that happen.
And she'd probably be motivated at that point because she would know.
I would hope so. I mean, I think stopping nicotine products are arguably one of the harder things to do in life. So, of course, we'd want to tackle that. I would say more commonly what we see in our practice is tackling insulin resistance and elevated blood sugars, which I think is probably, again, one of the most common things. Not only does that where we talk a lot about lifestyle changes, or, what we name is our seeds, or our seven essential elements of daily success, but there's also a lot of medications that are available in a variety of different forms that can help lower that blood sugar. I have to sort of a pitch, of course, I think some of the new weight loss drugs that came out are expanding their indications to include sort of treatment for coronary artery disease, which is absolutely fascinating because they're sort of in this next chapter, right? The first chapter was, do they work at lowering weight and lowering blood sugars? The answer is yes, right? This next chapter is, do they benefit? Does that weight loss and everything that happens with these drugs actually lead to better outcomes in terms of all the things that people die from? I think we're leaning in the direction of yes, right? That's really an exciting sort of piece that's added on. So those aren't the only drugs that are available. There's a lot of different medications we would use in order to lower women's blood sugars. A third component is optimizing women's cholesterol levels. When we look at cholesterol levels, we're looking at a lot of different numbers. The basic panel is an okay snapshot into what's happening, but we definitely like to dig a little bit deeper and look at different variations of what we call your lipoprotein. So if you think about your liver making fatty acids and putting them in these big cholesterol spheres in order to move those fatty acids around our blood, there's different aspects of those spheres that are really important. And it's important to know the different components of the outside protein markers and this different sizes and shapes. And those are really important to optimize. Of course, there's a lot of different cholesterol medications that are available. You know, the one that we talk the most about is the drug class called statins. Those help not only by sort of lowering the count of those cholesterol particles, but they also have been theorized to help stabilize that inflammatory wall. And so that's why the cardiologists sort of are really pressing anytime a woman has coronary artery disease to be treated with a statin, regardless of their actual like LDL count, which is sort of the traditional number that we would look at.
Well, Celia, I think of a patient of ours, haven't seen her for a bit, but I just remember it was so like she just sticks in my mind because she saw us, she was 49. Her dad had a heart attack early, and heart disease was on her mind, but she was a runner. She was thin. Her muscle mass was 32. Her body fat was low. It was 26, 27. She was very fit. She was energetic. She didn't have any symptoms. She felt great. She's like, but I just want to be sure. So she had a CAC and it was like 300. So she had different, plaque and different arteries in around her heart. And she was like, how could this be? She was so upset. She saw cardiology. She didn't need any other intervention, but she had what you're talking about. She had a check of her lipid particles. Her LDL wasn't that high. Maybe it was 125, but then we looked at the particles and she had a really high lipoprotein A, right? And so because of that, I mean, she has this really sneaky, how do you talk about it? Like this naughty little sphere that gets in the wall.
So do you think again about your liver making these big spheres that are sort of floating around? There's all these, like, I think of them as little zippers on the outside, all these outside proteins that are there to do a variety of different things, help move these spheres into cells and sort of drop off different components. It's actually a very beautiful system when you kind of take a step back and look at it. But genetically, there can be some proteins that aren't supposed to be there. And they either cause stickiness to the blood vessel wall or they muck up the transportation system of these big spheres back into the liver, leaving more sort of to float around within the blood vessel, which just ends up getting lodged within the wall. And that's a genetic factor, actually. So there's nothing you can do in terms of your lifestyle to change that. There's a big push in cardiology that everyone should know whether they have a lipoprotein A gene or whether they make those particles. And we, of course, test in our office for that. But it's just sort of fascinating. And what you're alluding to.
Everything right? She was doing everything right.
We actually talk about in the obesity medicine world, there is this phenomenon of patients who maybe have obesity actually in this odd phase of life have an increased mortality in some of these aspects of cardiovascular disease, because if you're obese, doctors are looking really hard, right? They're looking for all these comorbidities. But if you're thin, like our patient, and obviously checking all the boxes of the right lifestyle things to do, doctors kind of just have shrugged and been like, no way, right? There's no way she could have coronary artery disease.
Right.
What we know is that is not true, that it is possible to have those things.
And what's exciting for her is that she went on a statin. She was able to lower all her lipid levels. And also she was still in the range where we felt comfortable prescribing transdermal or patch estrogen. And, she's likely to live a long, healthy life. And she now is plugged into the system. She's watching things really closely. And she's become a champion to really talk about how people can develop heart disease, just like Clint Eastwood's girlfriend, who wouldn't have been someone we think of as having heart disease.
No. Like I said, she did not look like someone who was ill by any capacity. And just, again, how tragic to sort of hear that story.
Exactly. So again, I love how we talk about, again, and we define this for people, again, what do you want? Where are you? What is the gap? And then what's your barrier? So the barrier for that last patient we talked about was knowledge, right? Like she didn't know that she had anything.
Yeah. And I think that another thing we talk to our patients a lot about, which I think is not 100% understood, is the role in stress in all this, right? So when we are stressed, it's not a biologic inert phase. We do have a lot of different changes biologically, either with our nervous system, our brain, our blood vessels, our liver. Things are happening, even though we maybe we don't acknowledge it as much, or we don't want to believe that it's happening, but that's true. And I think that it can be really helpful if you're doing so many other things right, but you just feel like you're living in sort of a day-to-day stressful environment, to reflect on if there's any ways that you can maybe optimize that, whether that's seeing a therapist, working on different coaching, either career coaching or income coaching, or other things that you can do to sort of bring that stress level down.
And I think then it's also, if you're in a stressful environment and things can't change immediately, it's how do you have the inside be, right? Like, we've all had times that are stressful. You and I don't have calm, boring jobs, right? We love what we do, but it's stressful, and having families and all of this. Like, I like my busy, crazy life, but how can I have my inside be calm? And so there's a lot of data around people who do a meditative practice, we talk about it as one of our seeds as metered breathing. Missy, if you throw up maybe the seeds link. I don't have that up there. But
the seeds ebook.
Okay, yeah. Good. So yeah. It's having that little bit of calm inside. So it's having that intention. I want to have a great calm day. I want to cope with what's going on today. But then it's having that little bit of gratitude in the moment of a stressful time, of just thinking about something you're grateful for. There's a lot of data that shows that even that little bit of gratitude can get you out of flight or fight, can stop that cortisol response, and can just let you settle. So these are the seeds. And again, I think we need this checklist.
And I think one of the great things about seeds is there's so much overlap, right? Because if you're not sleeping, it's really hard to make that mind-body connection. If you're dehydrated, your body's in no way ready to kind of make that biologic step to calming down, right? Exercise is a great way to just like let the mind sort of release and being able to move your body. And so what I love about seeds is it all sort of overlaps on each other, of how it can be important to sort of just get your body to where it needs to be, and your mind.
Exactly. Even not having enough water. I had a patient the other day who had this nervous feeling, and we talked about hydration, and she was, having maybe 3 glasses of water in a day, and she's having 6 cups of coffee because she's so tired. She's having hot flashes and night sweats. Like, she's just in this like anxiety mode. And even just drinking water, it might take 3 days to get her hydrated, but drinking that water will help her settle, maybe even bring her heart rate down a little bit, like maybe minimize some of the hot flashes. It's keeping your blood sugars level, so you're not doing highs and lows. Like the cookie I had at lunch today, I was sleepy and then I was hangry. And so it's just knowing how can we, why did I need that cookie? So it's just really looking at all those aspects of seeds. Yeah. And I love the seeds ebook. Thanks, Missy, for putting that up there. It's like people print this off from our website and just tack it up on their wall, and you've got this list to follow.
Yeah. And I think, one way that our lives have sort of overlapped, I think, is, again, to continue to reflect on the role of hormone replacement therapy. And I think we just have to, I know we harp on that a lot, and I'd argue that's sort of our bias of where we want to go. But Missy, if you could just throw up the slide in terms of looking at the role of hormone replacement therapy in sort of the development of some of these vascular lesions.
So this author is Dr. Hodis, and he is just so inspiring. The study is from the study called the ELITE trial, which looked at how women, when they start hormones early, it actually can reduce the risk of developing heart disease. And women who start it late or don't have it, then they develop heart disease earlier. So this very eloquently shows if women start hormones in the first 6 years, then again, the plaque is developing more slowly. So in the first column, it shows when women aren't on hormone replacement therapy, or for example, early menopause, they start to develop plaque in the wall, like we talked about, that you'd only see on a CAC. And then, correct me if I'm wrong, Sarah, and then as it develops and then it erupts and it starts to make the blood vessel more narrow. Whereas women, when they start estrogen early and they continue it, then they never develop that same degree of plaque ostensibly because the lining, the skin is healthier of that blood vessel.
Yeah, so that middle row is really what we're talking about of treatment with early HRT. And if you can look all the way to the right, what you'll notice in that second row, right, not only is there clearly obviously more red, which is alluding to more red blood flow, but there's just not that massive inflammatory process, which is going to lead to those complicated lesions that rupture and cause that like, sort of acute clot that we were sort of talking about, we get worried about. So even if you had a baby amount of sort of plaque buildup, which arguably most of us sort of will in our lifetime, it's not going to lead to that dangerous, complicated lesion that we all fear.
And then you look at the next row down where women started hormones late. So they already had plaque, they already had inflammation, and they start hormones that could even increase the risk of a heart event. So this is like a key takeaway from the WHI study. So the WHI study was in 2003, and the information that came out of that with very kind of a poor way of talking about it showed that, I have so many thoughts in my head. So out of that study came the fear that estrogen caused heart disease. And this study breaks it down and says if women started early, they have a lower risk. But in that study, the average age of women was 63, and their average time from menopause was 10 years. So if a woman is 63, no symptoms of menopause, more than 10 years from menopause, and she starts hormones, especially what was in the WHI was synthetic estrogen and synthetic progesterone. And that synthetic estrogen can go to the liver and make the blood sticky. And so what happened is that these women already had plaque. And so, again, the addition of synthetic estrogen would increase the risk of an event. And the only women in the WHI who had heart disease, had a heart event, they also had metabolic syndrome. So when people looked back at the data and said, let's figure this out more, they already had metabolic syndrome. So when Dr. Egan and I see a patient and we help her decide our hormone's right for her, we look and say, if you have metabolic syndrome, we need to make sure you don't have active heart disease because that would preclude your ability or your safety of taking hormones. I think this is fascinating because unfortunately, that study or how it was announced kept a whole generation of women from getting the benefit of estrogen. And people out there still now, the fear just keeps going. And so Dr. Egan and I, it's like our mission, how can we help people understand that actually it's safe? You just have to follow some guidelines and some rules.
Yeah. And as you know, not that we like to put pressure on women, but we do sometimes try to speak very clearly about time is a factor here, right? We do have a period of time when we really would love to see women make a decision about whether or not, they would be a safe candidate and want to do hormone replacement therapy, within that 7 to 10 year range, because we are concerned that they may miss that sort of window of it being helpful, and if not dangerous towards the end.
Right. I saw a patient recently who said, please tell every woman, I wish I would have started it earlier. So she is 60 years old. She had a CAC of 77 and she just was hesitant. And we talked about the data and I said, I'm not here to tell you what to do, but here's the data. Here's the possibilities. And she decided to try it. And she came in and she was like, I feel so much better. And I wish I had started it when my CAC, she had 2 CACs. So she had one 6 years ago that was 0. Mm-hmm. And then 6 months ago, it was 77. And she's like, I wish I had started it earlier because she was doing everything else right.
Yeah.
Anyways.
Yeah, that's frustrating. But I feel like, again, women, talk to your friends, even if they're trying to be convinced, right? Just be like, watch the next 30 minutes just to get an idea of what we're doing, right? And that's what informed consent is, right? If women can know everything and they still don't want to do it, that's fine. That's their choice, right? But I think the problem is that women don't have all the information and then they're making a decision without clearly knowing. And we don't think that that's fair for them because women deserve better than that.
Exactly. And again, informed consent is so important. And I don't think the care of a woman should depend on the level of training of her provider. So, women out there, if you haven't had good informed consent about pros and cons of estrogen in terms of your situation, it can be really helpful to find a certified menopause provider. So I'm an obstetrician, gynecologist. Dr. Egan is an internal medicine doctor. We're both menopause certified. So in your area, you can find a doc who's menopause certified by the Menopause Society. And that can be a really helpful way to make sure you're going to get really good informed consent. It doesn't mean you have to be menopause certified to give this consent, but you deserve to have the best knowledge so you can make the best decision for yourself. Thanks, Missy, for that. So yeah, check out menopause.org and you can find a provider in your area.
All right. Well, I think we're moving on to our questions.
Good idea.
And please, if women have any questions, this will be the time if you want to ask us any questions about cardiovascular disease or hormones or menopause or anything. We're always here to answer. All right. So what are our 5 take-home tips?
So number 1, know your phase of ovarian function. So just like Celia, you were saying, in the critical care unit, you're not thinking about someone of, are they in menopause or not? And at that point, unfortunately, it might be a bit late for that conversation. But yet, I really feel like this should be in the assessment and plan of every patient in the country. So in medicine, we use a SOAP note, subjective, objective, assessment, plan. So in the assessment, I think phase of ovarian function should be right there. So all of you out there, you need to know your phase of ovarian function. Are you in reproductive? Are you in perimenopause? Or are you in menopause? If you have an IUD, if you've had a hysterectomy, if you haven't had your periods because of chemotherapy, all of those things, it really helps to have a definition around this. Celia, how has this helped you since you are here and thinking about this more?
Yeah, I mean, I think learning about all the symptoms that come with perimenopause and early menopause, I think it affects a lot of different aspects of women's bodies. And a lot of the times we'll have these, women will come up with different complaints that may not fit into a standard box. And it can be helpful to know where they're at and help guide treatment options, or really know when to sort of push other testing. Again, coronary artery disease or obstructive coronary artery disease, the symptoms for a man are completely different than a woman. And a lot of times women's symptoms can be really subtle, like nausea, a little anxiety, sense of doom, maybe a little shortness of breath. I mean, those are kind of things that we experience a lot. Women will talk about experiencing anyway. But if a woman's in the perimenopause or early menopause phase, we may be sort of very, very hard pressed to sort of push sort of advanced cardiac testing, without needing the crushing chest pain, or at least we don't want to wait for that.
Well, I'll never forget, I had a patient who was in late menopause. Her hot flashes had been gone for a decade, and her primary care doc sent her to me because all of a sudden she was having new onset of hot flashes at 72. Now, when hot flashes start at 72, they're not from low estrogen. That's from something else. And as I've been taught, that's either heart disease or it's anxiety. It's one of the two. And hearing her story, her hot flashes would happen when she would walk to the mailbox, but she felt better when she stood by the mailbox for a minute. And then she would walk back to the house and her hot flashes would get worse again. I mean, that's heart disease until proven otherwise. So I sent her for a stat consult. She had a stress test. It was positive. She was admitted and she had a stent. Her hot flashes were not, again, from low estrogen. They were from angina or her obstructive heart disease. So again, it's important to know phase of ovarian function in terms of even helping delineate what might be a sign of heart disease.
Yeah, absolutely. All right. Number 2, understand and know your family history. Again, very similar to that patient, right, who's doing all the right things, but really her only major risk factor was her family history. It can be really helpful to know sort of everyone in your family's history, particularly if they've ever died early. So a lot of times people say, I don't know, my uncle or my grandfather died young. We're not sure what happened. And it can be really helpful to know whether or not they sort of died from cardiovascular disease or something else. A lot of the times men will die in their early 40s if they have some of these genetic problems that women will sort of pick up in their early 50s. And so it is really important to understand your family history. And sometimes it can be tough to ask some of those questions, but it will benefit you in the long run.
And some of the risk scores for heart disease, there's the Framingham risk score, which has been traditionally used. But the Reynolds heart score, when that was developed, it uses a family history of heart disease as well as the CRP, which isn't used in the Framingham as much. And that moderate group in the Framingham, you apply the Reynolds score, which includes family history of premature heart disease in a first-degree female relative, then all of a sudden you now have separated people into a higher or lower risk factor. So I think it's fascinating how this does impact women's heart disease risk even more than a man, as I understand it.
Yeah, right. Number 3, know your numbers and lab results. So, and it's really important to know kind of where you're at in terms of your sugar processing, where your cholesterol levels at, and maybe not just where they are at this year, but what's the trend been, right? If you've noticed that over the past 3 or 4 years, you're sort of really getting this uptick in your cholesterol levels, which can happen with perimenopause. We do see sort of this huge influx of increased LDL numbers, then it's really important to start talking to your provider about what that means and what you can do to prevent those numbers from rising even further.
And I think it's really fascinating, like maybe when you're 25 and 30, maybe every 5 years for cholesterol, I'd love to know. But as we get closer to perimenopause, then we want those levels every year so we can see that trend. And, too, it can be important to have that particle breakdown. So, for example, my cholesterol is reasonable. My lipo-A is okay. I did a Boston Heart at your recommendation. But my lipo-B is high. So now I'm taking Zetia, which is a medicine, I don't know, you know about that, right?
Yeah, so Zetia helps block the absorption of some cholesterol particles from your GI tract, which go to be made into packages and sort of travel up through your liver and do their thing. So that's how Zetia works. It's been shown to sort of reduce some of those numbers, not quite as the same as statins, but they can be sort of a nice addition to statins, or if a patient can't tolerate statins for whatever reason.
So yeah, so important to know your numbers, but also know your blood pressure, right? Because I think about blood pressure. When blood pressure is high, it can damage that blood vessel and then damage the skin, right? So it's like, and you push this hard, blood pressure control.
Yeah. So, I mean, blood pressure is not only are we talking about sort of shearing through those blood vessels and sort of nicking the lining, which then ends up creating sort of that scarring and that sort of oozing that we were talking about. But something else that is really important with blood pressure, which we didn't really dive into deep here, is actually your heart function. So, most of our talk tonight has been about obstructive coronary artery disease and how the heart is receiving blood. But what internal medicine doctors think a lot about is the squeezing and relaxing function of your heart. So if you have decades of high blood pressure, what ends up happening is your heart, which is a muscle, is working really hard to squeeze against that high pressure that's there. And just like any other muscle, that muscle will get kind of big and beefy. The problem with that is it doesn't affect so much the squeezing, but it affects the relaxing. And if you can imagine, the time that your heart relaxes is when it fills with blood from your lungs, which is really important, right? But if you have a big beefy heart and it can't sort of relax in the way that it should, it doesn't fill the way that it should, and all that blood gets backflowed into your lungs and sort of back into your liver and legs, and it causes a whole host of problems. So not only is blood pressure control important for sort of preventing obstructive coronary artery disease, but it's important for a lot of other factors, including what we'll call your systolic, or the squeezing function, or the diastolic, the relaxing function of your heart. This sort of tends to come up a lot when women are in their 80s and 90s, right? That tends to be one reason why women struggle with health sort of in that kind of later chapter in life, because a lot of those symptoms have sort of progressed to later stages.
And it can really affect quality of life. And I love the concept of what we do at 50 determines 80. So
yeah, absolutely.
Ladies, make sure you know. All right, next one.
Know the resources available to you, right? We talked a lot about different imaging studies, different labs, different medications, right? It's really good to know where in your area can you get these things done. Most hospital systems are sort of picking up calcium scores, but not everywhere, right? And it can be really helpful to find out where you can sort of get some of this stuff done so that you can know your numbers.
Exactly. And for example, the CAC test right now is not paid for by insurance as a screening test, which is so frustrating. I just found an article that showed that CACs are helpful for everyone as a cost-effective tool for prevention, and yet insurance companies don't pay for it. So it's just so important to know that you can pay cash. Here in our area, it's $250 cash at the local healthcare system to have this done and read by a radiologist. So It's not thousands of dollars. It's affordable hopefully for many. But again, it's knowing what's available and finding a provider who knows about it and can order this for you.
And a lot of those the looking more closely at your cholesterol levels, we call those advanced lipid markers. Of course, our office sort of sends them out to a lab that's on the East Coast, but there's a lot of companies now that sort of are looking at labs, and I think a lot of those things are becoming more readily available sort of on the internet with companies that know that patients want this. And so it can be really helpful to sort of look into that to get some of those numbers. And I think everyone should at least get an advanced lipid marker set done at least once to kind of see where they're at with some of those genetic factors. And even just to make sure there's nothing sort of sinister lying in the way that your cholesterol particles, again, the size, the shape, the different protein markers.
And just another thing too is like resources are cardiologists, right? And there are preventative cardiologists, but it's so important to know, does that cardiologist know about heart disease, how it's different for women than men? And there's a group of studies called the WISE studies by Dr. Barry Merz as the first author. Has the cardiologist read the WISE studies? Like, I just think, maybe I'm a little bit dramatic about that, but I think it's so critical that we women are treated. We're not just little men. We are different than men. We form heart disease different than men. So it's really important to be empowered to ask that question. Missy has a question. Your CAC at Grand Haven, that's awesome.
Yeah, only $150. I think that the overall price, I think, is coming down just because there's more sort of companies and different centers that are offering these tests, which is great.
Yeah, thanks for sharing.
All right. Yeah.
Oh, go ahead. We've talked about this a lot.
Yeah, your HRT and your personal options. I feel like we've talked a lot about this. I think that, that snapshot of looking at the progression of coronary artery disease with HRT, without HRT, based on the different timing is so powerful in terms of, in terms of what you want to do. And again, maybe for you, HRT is not where you want to go, but at least you'll have a fair understanding of your overall risk in terms of progressive coronary artery disease, if that's you.
Well, and just to show you, so in the workbook, we have the informed consent. And even now, at True, you can go on, we have our basic wellness course. And there's, there's an ability to have informed consent. So it's basically knowing what are the symptoms and what are your options and what's safe for you. So again, this information is available. It's not rocket science. It's just really important to have an evidence-based discussion.
Yeah, great. All right. 5 questions to ask your primary care doctor.
We can't talk about this enough.
What is my phase of ovarian function? Awesome.
So make sure you're knowing someone or seeing someone who knows and can talk about what is your phase.
I guess I'd run if they say, I don't know and I don't care, right? Maybe find someone else if that's their answer.
That's right. And number 2.
What is my risk for early heart disease? So again, it's understanding all the different risk factors that are at play, having a doctor who's maybe willing to draw a hemoglobin A1C, which is looking for, your overall average blood sugar over the past 3 months. We've heard some doctors may say that that's sort of not indicated for maybe someone who doesn't have a impaired fasting glucose. We sort of don't believe that that's appropriate. And we think a lot of women every woman should have a hemoglobin.
Well, we see it all the time, right? I had a patient the other day, her fasting blood sugar was 89, her A1C was 5.9. So she is impaired, right? She's in pre-diabetes range, and that really helped her understand her symptoms, her cravings, why she's gaining weight, why she doesn't feel good. It really helps people be empowered to make better choices.
Yeah. So again, looking at all those risk factors. All right. Number 3, do you know about the coronary artery calcium score CAT scan? Again, this is, I think, becoming something that most doctors know about, but you definitely should have a doctor who would be willing to order it for you and kind of give you a view of what that looks like and your overall risk.
Yeah. And it's something that just more and more is being talked about. I remember last year I was at the Menopause Society meeting and there was a lecture about the CAC, and I was very proud that we had already been ordering this for years. And it was something that a lot of people in the audience still were new to. And again, all the respect, there's a lot of stuff out there. We know that it takes about 10 years to go from research to trenches, right? So from the research and the big institutions down to the small community practices. So it takes a while. So again, we can speed this up by you all out there asking your doctor for the test. And then it pushes the doctor to get more educated. So it takes time, and it takes all of us. Go ahead.
I would say about 8 years ago, I remember being in grand rounds at a hospital center where I worked as a hospitalist, and it was about CAC scores and comparing it to, they had to sort of validate it, right? Comparing it to a stress test, comparing it to events later. And that was sort of the beginning about 8 years ago of sort of starting to get some of this information. Funny that it was in a hospital grand rounds, just because in general, most of the time those are the doctors that are dealing with the complications of heart attacks.
Right,
so it's
not preventing.
Yeah.
You want to answer this question, Sue?
Yes. So Sue asked a great question. If my first CAC score was low risk, how often should I have another? Sue, that depends on your other risk factors. So if you're someone who has a lot of risk factors, then we would suggest having it frequent, maybe every 1 to 3 years. If you're someone who has a low risk, then we would suggest every 5 years. Again, some of this has not been 100% teased out because all this stuff is relatively new. We're starting to collect data about what this looks like, but that's sort of where we stand as of right now with our recommendations, which are sort of in line with what they would do at like a big cardiology center like Cleveland Clinic.
And especially one of the risk factors, if estrogen isn't safe for you, or you've chosen not to take it, then that would probably be a reason, right, to check a little bit sooner.
Yeah, I think, we think of those big risk factors. So maybe not having estrogen, being a smoker, worsening blood sugars, and maybe uptrending cholesterol levels, or a very strong family history of heart attacks, meaning a lot of different members of your family are having a positive lipoprotein A, would all be reasons why we maybe speed up that pace of having a CAC score.
Yeah, love the question. Thank you, Sue. All right.
What are my treatment options for reducing my risk for coronary artery disease? Right. So you're hoping your doctor's pretty, up to date about and aggressive with treating your sugars, maybe considering some of the weight loss medications if you're a good candidate, treating your cholesterol levels. Obviously, if you're a tobacco user, really working hard at getting you off tobacco products, and really being quite aggressive with bringing all those risk factors down with any medications. We hope that they'd have some sort of lifestyle plan, right? Some guidance on where to go in terms of activity and what to eat, or at least some resources sort of to point you in the right direction.
Right. So Julie asked a question, and I'd like you to test me on this one, Celia. So my answer would be no, you can't reduce it, but we want to make sure we don't progress it further. Is that correct?
That's correct. I mean, I think there's some cardiologists with some different dietary stuff have seen a very small
very
change.
Extreme, right?
Very extremely small changes that some are arguing may just be little data blip points. But I don't think it's ever enough to sort of tell people to not continue to look at CAC scores, nor not take a medication in order if they're only sort of doing kind of extreme lifestyle changes. But no one,
because it's calcified, right? The plaque is in there and it's calcified.
Yeah.
To keep the inflammation down.
Yeah. Yeah. For the most part. Yeah.
So don't be discouraged, Julie. It's just all about keeping it where it is and keeping that skin nice and healthy and smooth over top of it.
All right. What are my gender-specific recommendations to reduce my risk of heart disease? So again, we're talking about thinking about hormone replacement therapy.
What I was going to add is even looking at what I just thought of, gender specific. If you've been pregnant and you've carried a pregnancy, if you had severe preeclampsia, that would be a risk factor for early heart disease. And because we know severe preeclampsia is a disease of the endothelium, or that skin of the blood vessel. And so if you're someone who had preeclampsia, again, we look closer. So that's not, I guess, looking at that as a way that we'd want to look for risk factors quicker, but that is a gender specific. Also, if you had gestational diabetes or diabetes of pregnancy, that itself is a risk factor. So we need to really look at that.
Yeah. And I think some of this is all about timing, right? So if you're someone who has preeclampsia, maybe as soon as it was safe to get radiation, we talk about doing a CAC score for that patient versus waiting until they were, 50. We'd be probably a little more aggressive with some of our screening modalities of looking for
doing a lipo A early.
Yeah, absolutely.
Exactly. I think we could talk about this forever and for hours. And I'm just, again, so honored to have you here at True with the Practice. How long have you been with True now? Like 3 years?
3 years now.
Wow.
It's very exciting.
So we're 4.5 years old. So we're getting there, and we're just loving what we get to do for women. And I just look forward to being curious and learning more and more and bringing this to more people. So
So if you can't see this in the office, please check us out on our website, where we have a lot of different options now for women sort of seeking answers and guidance on their next stage of life, or any stage of life, to be honest, right?
Exactly. So yeah, we take care of people from 15 to 102. So it's just know that it's never too late to live your best life. And we hope that you live your truth and be well.
Have a good night. That's right. All right. Thanks.